Okay, hello and welcome to the Sex and Drugs Ongoing Syndemics in the PrEP Treatment Era oral poster discussion session. My name is Heather Marie Schmidt and I'm from APCOM in Thailand. I'm also from the New South Wales Ministry of Health in Australia.
Hi, good afternoon. My name is Peter Preko. I'm with ICAP at Columbia University. I'll be co-chairing this session with her.
So HIV does not exist within a social, political or economic vacuum. In the context of HIV, syndemics are the social, political, economic context that work synergistically to disproportionately increase HIV risk and the burden of disease. The total is more than the sum of the parts. It is important that with the increasing adoption of PrEP as a crucial prevention tool, that we start to look at syndemic factors that play an important role in helping to identify people who might benefit from PrEP or other HIV prevention. We have 6, hopefully, fascinating presentations examining different syndemic factors across drugs and alcohol, mental health, and others. Our first speaker is Satya, Sethi Narayana, and he's a graduate student in clinical psychology, PhD program at the University of Miami. He earned his BA in History and Literature from Harvard College, his JD from Harvard Law School, and his post-baccalaureate certificate in psychology from UC Berkeley.
All right, thank you for that introduction. So I'd like to, in addition to acknowledging the funding sources for this project, I wanted to thank my co-authors, in particular my mentor Steve Safran for connecting me to this project, and Brooke Rogers for leading the statistical analysis of the data. So when we think about syndemics, we usually discuss them in the context of populations that are at risk of contracting HIV. However, less is known about the HIV transmission risk that's potentially created by syndemics occurring in HIV-infected patients, particularly those receiving clinical care. With that in mind, if syndemics are predictive of transmission risk, then syndemics could also help us identify patients to receive psychosocial interventions to help us curb new HIV transmissions, in addition to improving their overall well-being. So to explore this question, we turn to data from Syndemics. Now, Syndemics is a network of CFAR sites that are providing patients with clinical care. So in addition to receiving their medical care at one of these Syndemics sites, they agree to share some of their medical information in addition to patient-reported outcomes at visits that are spaced at least 4 to 6 months apart. So we had about 16,000 patients in our sample that were seen between 2000 and 2017 for a total of about 69,000 visits. So we had about an average of 4.5 visits per patient. And if you look just briefly at the breakdown of demographics in terms of our sample, you can see the gray bars indicate cisgendered men who have sex with men, so they're well represented in pretty much all ethnic and racial groups. But you also see in the light blue among Black patients a more substantial representation of cisgendered women. So we decided to focus on 4 syndemics that were the product of patient-reported outcomes at these patient visits. So we identified depression, anxiety, alcohol use, and drug use as our syndemics. So in terms of our modeling, we used multi-level modeling to model the number of syndemics, time, and behavioral risk group. And our outcome variable was the presence or absence of biobehavioral transmission risk behavior, which we defined as condomless anal or vaginal sex while virally detectable with a partner of unknown or HIV-negative status. So you can see briefly on the left just a breakdown of the number of syndemics by risk group at their first visit, and then on the right, the breakdown of the presence or absence of transmission risk behavior. At the top, it's among all patients, and then at the bottom, it's among virally detectable patients. So you see that even among virally detectable patients, only a small proportion of patients are actually engaging in transmission risk behavior. So in terms of our results, I want to work from the bottom up. So first, comparing patients to one another based upon their behavioral risk group. We didn't really see many differences in terms of the odds of engaging in transmission risk behavior, with one exception. So with cisgender women as our referent group, we found that cisgender heterosexual males had 44% lower odds of engaging in transmission risk behavior. working our way up to the next bullet, between patients' syndemics. So if we compared patients to one another based upon their average number of syndemics over the time that they were in the Scenics database, we found that patients who had a higher average number of syndemics tended to have higher odds of transmission risk behavior. So specifically, for each additional syndemic in somebody's average number of syndemics, they had a 1.84 odds greater of engaging in transmission risk behavior. Next up, with respect to within patient syndemics, so in addition to comparing patients to one another, we also compared them to themselves. So whenever a patient went up in terms of the number of syndemics, they also increased their odds of engaging in transmission risk behavior. So for each one additional syndemic that a patient was observed to have, they had 2.04 greater odds of engaging in transmission risk. And then the last bullet, time, so we found that at each subsequent visit, patients had 23% lower odds of engaging in transmission risk behavior. So in terms of our conclusions from this data, we think that identifying syndemics via patient-reported outcome measures in HIV clinics is feasible, and then integrating the identification and the treatment of syndemic conditions within HIV clinical settings can help us potentially curb the number of new infections via biobehavioral transmission risk behavior.
So we will save all of our questions to the end. If you have any burning questions, please keep them, and we will ask you at the end. Our next speaker is Stephanie Parent. Stephanie has an ongoing dedication for improving health and human rights for marginalised populations. She performs research focused on addressing the determinants of health to improve the lives of people living with HIV, HCV and substance use issues, both locally in Canada and globally in Africa.
Hi everyone, so I'm Stephanie, and today I will be talking to you about correlates of opioids and benzodiazepine co-prescription among people living with HIV in British Columbia, Canada. It's a bit of a mouthful of a title, but hopefully it makes sense as we move along here. So opioids and benzodiazepine co-prescription are not recommended by most international guidelines because there are various health harms associated with this practice, including increase in respiratory depression, increased overdose risk, and increase in mortality. However, people living with HIV may have comorbid conditions requiring the use of both these medications. So the objective of this study was to estimate the prevalence and correlates of opioid and benzodiazepine co-prescription in people living with HIV in British Columbia. And we used the Stop HIV/AIDS in BC cohort, which is an administrative cohort that includes all people diagnosed with HIV in BC between January 1996 and March 2015. So it's a very extensive cohort. And we found that throughout the study period, 26% of our participants were co-prescribed for a median of 11 days. Our GEE model showed that being female, calendar year per 10-year increase, and substance use disorder were negatively correlated to co-prescription, whereas age per 10-year increase, mood disorder, and anxiety disorder were positively correlated with being co-prescribed. However, these findings have to be interpreted with caution because there is a paucity of evidence on the usefulness of co-prescribing opioid and benzodiazepine for people with comorbid needs, such as people living with HIV. The guidelines I was referring to in the introduction that was cautioning against co-prescribing are general population guidelines. And we know that people living with HIV have different health challenges than the general population. For example, in our study, people who were female or who had a substance use disorder were less likely to be co-prescribed, which may be good news. It may mean that they benefit from a better evidence-based care. However, it might also mean that they're being under-prescribed for their needs. Nevertheless, because of the high risk of co-prescriptions seen in people with mood and anxiety disorder, and because of the pretty serious health harms that can be associated with this practice, careful monitoring of prescribing practices is warranted to determine their appropriateness in these circumstances, that is with people with comorbid condition and living with HIV, or whether other treatment modalities, such as, for example, cognitive behavioral therapy, might be better suited in these circumstances. Thank you.
I'd Our next presentation is going to be on behavioral activation, behavioral activation integrated with sexual risk reduction counseling for high-risk MSM with crystal methamphetamine dependence, an initial randomized control trial. And Dr. Stephen Safran is going to step in for Matthew Miranga. Thank you.
Yes, hi everyone. Sorry that I'm not Matthew. I'll try to channel him and do a good job on the talk, as good as he would have done. But he is sick, and so I am giving his talk. This study we've worked together on, so at least I'm a co-author. We started this program of research when we were seeing a lot of infections in the Boston area in men who have sex with men that were happening in the context of stimulant use and more specifically crystal meth use. And what we were seeing is that these guys would with the context of crystal meth use, narrow other activities in their lives to the point that really the only thing that they would be enjoying would be the mixture of crystal meth and sex. And so the intervention that we developed, we drew from cognitive behavioral therapy, is a behavioral intervention for the treatment of depression that is called behavioral activation therapy. And the goal of that is actually quite simple, but it's to try to treat people who are depressed how to re-engage in life activities that they would find pleasurable, not sexually pleasurable necessarily, but it could be, but pleasurable, and that they would have a mastery experience, feel better about themselves by doing it. And we thought we could try to adapt that to integrating counseling to reduce stimulant use, as well as treating this symptom of depression that's called anhedonia, where you just stop doing things that you would normally do. So this slide kind of depicts the rationale for the study, as well as some of the statistical analyses. The outcomes, we did a small randomized controlled trial. The outcomes were condomless anal sex acts with HIV-infected or unknown status partners, so we tried to get people before they were positive in this. And we tested the intervention effects via Poisson distribution, log link, and all analyses were conducted in SAS. Again, it was a pilot randomized trial, so hopefully you can see the consort chart here where we randomized 41 individuals. You can't see it. I'm sorry. People are laughing. Blame Matthew. He's the slide person. Okay, anything bad that happens, you blame Matthew afterwards. But anything that's good, just say good job to me after this is over. Okay, so I guess it's probably hard to go through all the demographics, but their poster is outside, and you can kind of look at that within the context of me having to talk in 3 minutes. So what our results showed in our initial trial is that we did see some nice outcomes on the outcomes of interest. Is this showing? Yeah, okay, great. So IMPACT is the name of the intervention, and at the 3-month assessment, we saw decreases in condomless anal sex with serodiscordant or unknown status partners compared to the standard of care control group. And same with the 6-month outcome, it looked a little bit better. And then we also looked at sex while using meth, and we saw decreases there as well compared to the two groups. Another outcome that I forgot to mention on the prior slide is that people who got the intervention had longer periods of not using meth in the past 90 days compared to those in the standard of control group. So, you know, like a feasibility trial, we thought that the findings were encouraging and they provide evidence of feasibility and retention, initial efficacy for this group, that this treatment might be something to be tested in a more full-fledged randomized trial. And it also is behavioral activation is one of the simpler treatments for depression that could be potentially done with lay level or like not necessarily doctoral level therapists. So it could be more disseminable. And actually right now we're in the middle of where we just started a 3-arm randomized trial where we're testing this against an active control group as well as standard of care at 2 sites in Miami and Boston with not just crystal meth, but any stimulant dependence. That's it.
Thank you. Our next presentation and final one is going to be delivered by Dr. Venkatisan. I hope I'm pronouncing that well. Chakrapani from, he's the chair of and founder of and director of C-Sharp, a non-for-profit research agency in Chennai, and welcome DBC India Alliance Senior Fellow from the School of Public Health Postgraduate and Institute of Medical Education and Research. He's going to talk about association between syndemics and HIV-related sexual risk among men having sex with men in India. Findings from a large national behavioral survey. Thank you.
Thank you. Good morning. So I will present on analysis from a large-scale data set of National AIDS Control Organization. So this study was actually conducted by NACO among nearly 23,000 men who have sex with men across India. So my aim was to look at the presence of syndemics. So for those who do not know about the epidemic situation in India, India, the HIV prevalence among MSM is relatively high. It is nearly 15 to 20 times higher than the general population. And according to the government's own data, the consistent condom use among MSM is barely like 50%. So there is a lot of work needs to be done in spite of like more than 10 years of targeted HIV intervention being run by the government. So by this time, you know what do we mean by syndemics. So just to recap, it refers to co-occurrence of particular psychosocial health conditions. For example, it could be violence victimization, depression, drug use, alcohol use. And second is there should be synergy due to interaction among these particular conditions, synergy in increasing a particular negative outcome, for example, like a sexual risk or HIV infection. And third is the larger social forces which are operating in the production of these syndemics. So as I have mentioned, my objective was to look at are there psychosocial health conditions which co-occur among MSM in this in this data set, and whether those conditions synergistically increase sexual risk. So those were my aims. I'm coming directly to the results. So among the nearly 22,000 HIV negative MSM dataset which I examined, I looked at 3 syndemic conditions. So you can see they are occurring in epidemic proportions, like more than 10%. Violence victimization is 24%, alcohol use 27%. This is actually frequent alcohol use, not just any alcohol use. And then any drug use is 11%. You can see the overlap in the Venn diagram which shows the co-occurrence of syndemic conditions. So one simple way to look at the association is to just see whether as the number of syndemic condition increases, whether the sexual risk also increases. So you can look at this diagram and see that is actually the case. But a more robust way to find out a synergy is to actually do some complicated analysis, like in logistic regression. We have to introduce what is called as cross-product terms or interaction terms, and to find out whether these terms of, for example, violence and alcohol use, whether they become significant in the statistical model. So to simplify it, so this is actually the summary of that analysis. So if you look at the independent effects of the 3 syndemic conditions, violence, drug use, the odds of having inconsistent condom use are higher among those people who have this condition when compared to people who do not have this condition. Actually, the alcohol use was not significantly associated with sexual risk, but when the alcohol use is present along with violence, victimization, and drug use, then the odds of being in sexual risk group category was quite higher. For example, if you look at, I have mentioned as two-way interaction, if both the violence victimization and alcohol use was present, then it is more than the independent effects of violence victimization and alcohol use by nearly 1.2 times odds more than when it is happening individually, like independently. So statistically, this is actually showing that there is evidence of synergy among like co-occurrence of 3 conditions. There is synergy, co-occurrence of a particular 2 set of conditions. There is a synergy. So what is the programmatic implications for this? Like if we can demonstrate synergy, then what is the program implication? One is this is a National AIDS Control Organization dataset. NACO usually used to say syndemic conditions like, for example, mental health, alcohol use, those are not our concern because they are not directly related to HIV. So if we can demonstrate there is association with sexual risk, and if we can also demonstrate synergy, then which means we have to simultaneously address these conditions in the HIV program to have a substantial reduction in HIV risk. So those are the programmatic implications about this kind of analysis. So having, for example, NACO officials also as co-authors in this paper also actually increases the chances that they will incorporate syndemically oriented interventions in the national HIV program. So that's it. Thank you.
Thank you very much to all our speakers. They've done great with time, so we have a lot of time for discussion. So the floor is now open for discussion. I think we have 4 microphones lined up by the sides of the room.
Hi, Caroline Sabin, UCL. I've got a couple of quick questions for Satyanand. In fact, as the last speaker just told us, and we learned yesterday from Tonya's great talk about syndemic theory, it is really the interaction between those factors that is what defines a syndemic. So the first question is, have you looked at interactions? Because, of course, you've looked at the count of the number of things. And then the second question, which follows on from that, is you mentioned interventions at the end. I'd be interested to know a bit more about the discussions you've had about that, and particularly discussions with your patient community. I'd be slightly worried. You're getting very, very good quality data through CNICS, and you rely on people to sort of be very truthful. I guess I'd be worried that if every time people came in, they felt that actually they were then going to get lectured on giving up the alcohol and behaving themselves generally, they might start to be a little bit cautious about what they share with you.
Sure, thank you for that. So I was also at the talk yesterday, and definitely in the course of the time of the conference, I've been thinking about the question of how these are interacting. So we haven't explored that in the data yet, and it is something that I'd like to spend more time on for sure. So with respect to the psychosocial interventions, so I think there are some interventions, particularly with respect to depression and adherence, that we've had some success with, particularly a form of CBT that's a modular form of CBT that's targeted towards addressing both depression and adherence. But I think there are also other types of interventions that we're looking at with respect to reducing substance use that are both affirming in terms of the patient community. And it's not that we want to stigmatize people with respect to sort of the type of intervention that we provide. So I think there are other things that we're exploring with respect to affirming and non-judgmental sort of approaches to substance use in particular. Yeah.
Can I just say something about the interaction terms, though? Because we tend to get that as a criticism in a lot of our papers. And I've been in debates with Alex Tsai, who is one of the ones that really wrote the seminal critique of syndemics, as additive effects. And as a clinical psychologist, I think that it's really if someone has more of something, I think it's very clinically useful to know that. And so if you have one thing or two things or three things, and you can kind of know what to do with it. But when you start in with, let's say you're looking at, in this case we had 5 syndemics, but let's say you have 7 or 10 in an analysis, you can't test every single interaction term. And then when the results come up, you can't, okay, so now you know that, substance use and housing together are one interaction term that's significant. And depression and childhood sexual abuse might be another. But what you would do clinically with any of those things would basically be the same if you knew that, the person had one thing or two things. So I worry a little bit about the practical significance of this kind of forcing the interaction term into the analyses. So just kind of saying it, I'd say it's more debatable. I think it's great, in Venkatesh's, let's call you Venki, I'm sorry. In Venkatesh's talk, we've known each other for a while. When you have 3 syndemic, you had 3 in yours, right? In that way, it's much easier to do the analysis and understand the analysis and make, I'd say, clinical recommendations. So depending on like what the syndemic is for the population, I think sometimes it can be useful, but other times I just think it's so impractical, and you start, losing statistical power for, doing multiple tests, and it's really complicated to do the modeling. So, sometimes keeping it simple makes it more public health significant, in my opinion.
So I'm liking the discussion now. This is quite lively. As a statistician, I would say you can actually test every intervention. You've just got to have the right numbers in your study. And I would think with Syndemics, because it's so large, you potentially do have the scope. I'm not a behavioural intervention expert by any means, but I guess this is where mixed methods research really comes at the fore, because what I guess you want to do is you find something that you think is an interaction and you want to know if it's real or not. It's really trying to understand what is going on there and what drives it. And I suppose what I think is interesting is how, if you can learn from the drivers behind those syndemics, so what is it about, say, drug use and depression, that when you put the two of them together, it makes the outcome even worse. If you can understand then you probably do need to think of interventions that are very specific to that interaction. But I agree, you need a lot of research and good qualitative data to support that.
Thank you. I don't see anybody. Okay, sure. Please, can you move to the mic? I see another hand at the back. If you can get close to the mic, please. Thank you.
Hello. Yes. My question goes to Dr. Safran. In your presentation, that how can you engage those MSM to the live activities that they feel pleasurable? And my second question is that, is it the same like to promote some kind of intentional activities? If not, what's the difference? Thank you.
We do try to promote activities. So, the functional way that it happens is that we have this 5-page list of positive events that people generally like. And we sit there and we go through that list with somebody and we say, okay, one of the things is gardening. One of the things is going to the movies. One of the things is reading magazines. And it's do you like that? Do you like that? Do you like that? And at the beginning, before you go through the list, people are like, oh, there's nothing I enjoy. I don't like anything. But when you go through this, and it's boring as a therapist to sit there and go through this whole thing. It's not, but you spend, I'd say, 45 minutes with someone at the beginning, finding out things that they enjoy. And there's always a lot of things, free things that they can do, walk on the beach. We live in Miami, but walk outside. Dogs, cats, knitting, whatever. And you try to just get people to try doing these things again. And slowly, and you tell them, you're not going to like it at first because you haven't done it in a long time. But slowly you relearn how to enjoy pleasurable activities. You might not enjoy it as much as you enjoy crystal meth and sex. You won't. But it is a way to rebuild your life, and you do motivational interviewing also to kind of all the things that crystal meth has done bad for you.
So it's the kind of intentional activities that you promote?
Yeah, you schedule it, you promote it, you schedule it, you try to come up with a plan for them to try it twice a day, once a week, however the most is you think they can do. But they keep coming back, and you're trying to broaden their scope of activities that they can do by the time they're done with the intervention.
Thank you.
So we have another question.
Hi, my name is Leo. I work for Clinic Q, which is a trans and non-binary wellbeing centre and sexual health centre in London. So my question is, trans women are 49 times more likely globally to contract HIV. Obviously, in some countries it's much higher. Trans men are equally vulnerable to other MSM to contract HIV, and in some ways a lot more vulnerable. For example, 50% of trans men experience sexual assault, and many will contract HIV in that way. Despite these statistics and the realities of our lives, we're generally overlooked in both the research and service provision. So my question to the panel as a whole is, what efforts have you made to engage these populations, and will you be making in the future? Thank you.
Well, I'd like to respond as an interventionist. I'm also the director of a global gender center where we have over 300 affiliates, and we actually have a work group. And so we feel very strongly, and one of the first things we started recognizing in the need to develop interventions is we needed good instrumentation. So that's the first thing that they actually have started doing and get funding for. So there's a difference. I mean, if we want to know what works, we really have to really get good measures. So I do want to say that we've been on actually that mission for the last few years. And I agree with you. I didn't show violence issues. Violence is a big issue, and we have to deal with that as a nexus. When we deal with HIV, drugs, sex, and violence has been something that is critical, and I haven't seen enough on that here. But thank you. Gender-based violence, we have to talk about it.
Okay, so of course I also work with trans women communities. The HIV prevalence among trans women or Hijras in India is 7.5% compared to the national average of 4.3% among MSM. Of course, now government has also just, I think 5 years back, previously they were clubbing, like combining, including the transgender women under the MSM umbrella. Now they are also trying to disaggregate the data, and they also have some specific target interventions for trans women. So now I think things are picking up, but still not in a very good phase, which need to be done. Of course, of course, in general, one broader thing is like, for example, each researcher may have interest in a particular area. For example, people, if there are like 10, 15 population, people cannot ask me, for example, why you are not working on this population. So that is about the individual level, but broadly, I think if there is a research gap, we should have a research agenda in which we have to ask the government to implement that research agenda. That is the broader idea.
One way that we're trying to do more, and Matthew, who I'm filling in for, does have a history of like R01 funding for with Rob Garofalo on the Life Skills project. But one of the things that we're trying to do more in our studies, and maybe other researchers can do, is when you get a funded study that's not necessarily for trans individuals, to try to get some supplementary funds to do a pilot with trans individuals. And you can adapt your intervention and do formative work, but kind of as a way to begin. And we're hoping to do some of that with this behavioral activation study that I mentioned. But I agree that more needs to be done.
Okay, I think that it would be good for us to be included in more studies, but also not just as an add-on, but also as part of the main studies and part of the main service is really key as well. Because what we're getting, especially for example in service provision, is we go to a sexual health centre and we're just turned away because there's a disbelief that we could fit into those kind of categories, that that trans men do fuck men the way that cis men do. So I think that we need to be included in services and research on the same, as well as having additional things looking into our needs.
I agree with you. We actually have trans women in our women's studies because we ask we ask the person in a screener, how do you identify? So that's different from saying specialized interventions. Yeah. But we do not exclude. Yeah. And we develop individualized action plans anyway. So once somebody talks about their risk, that intervention becomes individualized to them, to their risk, once we identify what the risk behaviors are. So they carry that as a portable tool to work on over the time through case management and so on, so that they have something that they can own.
Thank you.
Do we have any other questions from the floor? So I've got a question for the panel. Wendy, you mentioned stigma and discrimination in your presentation and the importance in particularly the qualitative component. But for the panel, what do you think in your studies and the research that you've done of the importance of stigma and discrimination as a syndemic?
Well, I'm happy to respond to say that my next study, we think of a social ecological model. We are randomizing clinics first before we randomize our communities in a cluster design, so that we actually are using a stigma and discrimination. We're going to actually adapt it from some other sub-Saharan communities that have used it and have good outcomes, but we always have to adapt it to the context in that culture. But we really want to show the difference, and we know we need more structural interventions and to address stigma and discrimination in clinics, whether it's adolescents, whether it's trans people, or whether it's people living with HIV or drug users. The whole point of how people are greeted and treated, and people understand my motto in any study is, what can I do to help? We are here to be helpful as public health people, as clinicians, and it's not just about research, it's about being helpful. It's about having that attitude. And doing stigma and discrimination training and not just parachuting in, let's just do a workshop for an afternoon. But I've come to understand from other experts that have told me it takes days to do this. So you have to stop the work and rotate the people in, even though they never want to stop. They say, it's emergency, and actually entrench it into their work. So that's what we're doing. We're rolling out now.
So I think, some people may conceptually classify stigma discrimination as syndemic, but as I have shown in the first slide, ideally we have to see stigma, like societal stigma against, say, same-sex sexuality or transgender people as more of a social force, which lead to the production of syndemic conditions like, say, depression, alcohol use, or self-stigma. However, having said that, obviously we need to address the distal factors also, not just proximal factors like you screen for the individuals for the depression, alcohol use, but if you don't care about what is leading them to take alcohol or be depressed, then that is not a good sign. So we have to, in the intervention, ideally we should have multi-level interventions, both individual level intervention and also structural level intervention, but often doing structural level intervention is quite a challenge and fundings are not available. Yeah, thank you.
Hi, my name is George from Population Council, Nigeria. My question goes to the last speaker. First, thanks for your study showing frequent alcohol use isn't associated with sexual risky behavior. Nice to know that. But usually that result is divergent from the current global literature review that shows that alcohol use is associated with sexual risky behavior. So I was wondering, one, how did you define frequent alcohol use in your study? And two, when combined alcohol drug use, what was the output? I didn't see that in your presentation.
Actually, I showed that. That was the main point, actually. Okay, so anyway, I will explain. One is in the independent effect. If in the regression model, if you only look at the independent effects of violence victimization or frequent alcohol use and the drug use, the alcohol use was not significantly associated with that. So I actually looked at, it could be because of curvilinear association. I looked for the curvilinear association by looking at what is called quadratic term. I included a quadratic term. It was significant. And I did not show the diagram because that was not the focus of this study. So it was like a inverted U-shaped curve. So in the initial, as the number of days, it was like for 7 days. In the last 7 days, this is a national survey data. So whatever data they had, I analyzed. So so we actually arbitrarily took more than 2 days per week as frequent alcohol use because it is similar to consuming alcohol other than the weekends. So that was the rationale behind that, more than 2 days per week. But as I have told, it was like a U-shaped, inverted U-shaped curve. So obviously, as the number of alcohol use, number of days of alcohol use increased, initially there was a significant association, but then it was also decreased after say 5 days per week. So that is why in the logistic regression model, we can't able to show that because it was dichotomized. Mm-hmm. It was like a frequent alcohol use, yes or no. So that's why it was not significant. That is one. But coming to the interaction, the second question, actually, when alcohol use was not significant in the independent effect, but along with violence victimization or drug use, the interaction was significant. In both the three-way interaction and also in the two-way interaction between violence victimization and alcohol use, both were significant. So there was synergy when alcohol use is also there.
Okay, thank you.
Okay, so I think I have a question for the panel as well. I'm just wondering, in terms of application into routine service delivery, how do you see this happening? I work on a network where we are looking at developing a tool that will identify patients at high risk of disease, of HIV transmission, or high risk of disease progression, like patients who are on ART who may fail, in order to identify them, looking at structural, psychosocial, behavioral barriers that will cause them to kind of not adhere, and identify them and refer them for intervention before they actually, fail treatment or get lost to follow up. So I'm just wondering, how can this be applied routinely, such that this information can be collected in a non-stigmatizing way, especially in the general population, for example? And who will be the best health cadre to do this? Would it be peers, or even will people be open to provide this information to health providers if they are not peers? Thank you. Sure.
Yeah. So actually, I just completed one pilot study on syndemically oriented intervention among MSM. So I looked at 3 syndemic conditions. Of course, alcohol use, depression, and internalized homonegativity, that is self-stigma. So these 3 conditions. I worked with the government-supported targeted intervention programs, in which we trained peer counselors. So they screened for these syndemic conditions. Of course, for the research study, it was like, for example, for depression, it was PHQ 9, so you have 9 items. So for research purpose, I think the screening tool was a little bit longer. But if we want to incorporate in a routine setting, we have to use more smaller screening tools. For example, PHQ 2, PHQ 9. From there, we can take PHQ 2, something like that. If we want to think about incorporating into the routine care. So I think we can train the peers, and then we also deliver a brief intervention for, say, alcohol use or self-stigma, like psychoeducational intervention. Like WHO has motivational ensuring-based interventions for alcohol use, like 5-10 minutes brief interventions. So those can be delivered at the peer level. But if you identify, for example, an alcohol dependence or severe depression who requires medication, then obviously they have to refer to a specialist care, a psychiatrist. So that is the thing I followed. So my focus was actually, the outcome was on safer sex. So I actually found that when compared to the standard of care, if you have the syndemically oriented intervention, there was an additional net increase of 16% with male partners of consistent condom use. Thank you.
Thank you.
I've got a question for Stéphane from Association Aide in France. I'm listening to you talking about consistent condom use in different presentation, and I'm wondering right now with TASP and PrEP, how is that criterion still relevant and not underestimated because of those 2 new tools?
Sorry, so in our study, that was kind of before that. Took a little bit of time to get the study analyzed and everything. Our current study, what we do now is when we ask the questions, we first of all, if they're taking PrEP and they're adherent to PrEP, we count it as, I'm going to use the word protected sex, and we do dried blood spots to verify the PrEP adherence. So anyone that says that they're on PrEP, they do a little blood spot, and then that's how we'll analyze it in our current study. We spent a lot of time trying to think about what about the status of the partner, because this was for negatives, and the status of the partner on ART and the status of the partner on ART with detectable virus. And we just spent so much time trying to think about how to do that, and in the end, we couldn't come up with, especially for casual partners, we just didn't feel like, okay, so your last casual partner, were they positive? Yes. Were they detectable? Yes. But it's a casual partner. So in that sense, for the purposes of our analysis plan right now, we're not counting that as a protected event.
I want to say on my new adolescent project with girls and young women in South Africa, we are talking about condom use because of the STIs. And not all of them are on long-acting birth control. Many of them are doing that, but they do question whether they're going to stay on PrEP on it. They're not in any demonstration pilot project, so whether they are going to take PrEP on a daily habit is a question, because some of them feel like they're going to hide it from their family, but they may tell their family. Some of them may say they're going to hide it from their boyfriends because what does this mean? And so that's where our qualitative research, as you talk about mixed methods, has been very important. We've just analyzed all our focus groups. And so their opinion about the concerns about it as a daily use and still using condoms are, as we say, there are a lot of STIs. We're going to count all those outcomes.
I just want to emphasize, even if somebody is taking PrEP, obviously it is important to address the syndemic condition, whether they are depressed, whether they are taking alcohol, so that there can be better adherence. So, yeah, and also we talk about the combination HIV prevention approach. So in India, like, I don't know, like, when PrEP is going to come, there are like talks of PrEP demonstration project, but until that time, at least we have to obviously focus primarily on like promoting the consistent condom use.
And for quality of life, like looking at these syndemic things,
Yes,
like it's
yeah,
not
obviously.
just about the.
Yeah, we can't like have like compartmentalization. We have to provide holistic care, so improving mental health and also sexual health.
Right. So I don't see anybody by the microphone. I would like to just give final opportunity to the panel. Do you have any final thoughts before we wrap up? Any final thoughts?
Well, I'd like to thank you all for coming, because nobody's ever going to see where our posters are. They're hidden. It's a secret.
Okay.
So can you join me in thanking all of our panelists today?